With more healthcare being delivered from outside of the hospital walls and the increasing acceptance of virtual care in healthcare delivery, how else can virtual care better assist more patients and relieve stress on an overburdened healthcare system? This is session 4 of the Talking Health Tech Summer Summit, titled Evolving Models of Care. I'll be moderating a session with Dr. Malcolm Pradhan, the Chief Medical Officer and co-founder of Alcidion, who are helping healthcare organisations harness the power of technology to create a clinically relevant environment with digitally enabled care. And Richard Taggart, the CIO for Sydney Local Health District, who are providing healthcare services for more than 700,000 people living in the centre and inner west of Sydney and beyond. So I'll be moderating this session today and the next couple of sessions that you'll hear in this block. So we've got Richard and Malcolm who've joined us for this one. Hey guys, how you going?
Good, thank you, Pete. Feel like I should have brought my shorts and a nice hat with that nice summer beat in the background. It was wonderful to be here.
I'll tell you what, it's there's no summer vibes in the weather in Sydney today. That's so really got to represent.
You could be wearing your shorts right now, Rich. We couldn't tell.
we don't
keep an air of mystery.
Yeah, that's not this isn't the live stream that we need. But and Malcolm, I've got ultimate jealousy of the background there as well too. Only one upped by Malcolm Pradhan's live stream setup. I think that sets the standard globally. But,
yep, I've been spending a lot of money at IKEA recently, so yeah, that's what's going on.
Excellent. I think maybe we'll have to do a live stream, you and I, about like tips for everyone on how to like one up their live stream setup. But that's not why we're talking today. I really am keen to jump in and learn a bit from both of you. But I wanted to start with Richard in particular. Last time we spoke was about 12 months ago at the Autumn Summit. You spoke more broadly about, I guess, public health generally and the impact just moving into COVID and what to expect there. But we're about 12 months in. Tell us a bit about the challenges of the real world of, COVID and the setting that we're in now, particularly in a public setting and Sydney LHD.
Yeah, happy to, and it's good to be back. I think all of us have got a COVID story that we could share. I mean, for us as a health service, we found ourselves very much on the front line due to the location that we're at Sydney Local Health District. So our large hospitals in the inner west were seeing patients very early on in the very early days of COVID. But we also, because of our location, had to play an important partnership role with the borders and spent a lot of time at Sydney Airport, and then a lot of time providing quarantine services for people in special health accommodation over the course of the last almost 2 years for that time. So that's been really interesting, tearing down the traditional model of delivering acute and subacute healthcare and putting it into hotels and apartment blocks and airports, as well as dealing with the pressures of trying to run a normal health service when you've got staff who are furloughed by COVID or need to be working remotely because they're quarantining, and then patients who can't come in anymore and need to access care virtually. So there's been a lot happening. I guess we anticipated in our surge plans that the health service itself would need to surge to cope with the demand. I don't think any of us quite anticipated just how many of our staff would actually get struck by COVID during the course of the last 6 weeks. And I think it's a common story across the system. I think my own department, we had about 25% of our people go through COVID over the last 6 to 8 weeks, all caught from the community, people with young children, going back to school, people who live in share houses. So that's been quite interesting. It's really tested our surge planning, that's for sure.
Yeah, definitely. And Malcolm, from your perspective, no doubt technology is playing a big part in enabling all of this. You've picked up on a few of these challenges and helped with those along the way.
Yeah. So, I think as everyone, in the sort of vendor area, we've been scrambling to to support healthcare services through what's been a incredibly challenging time, and there's been a lot of discovery. We sort of always knew that out of hospital care was going to be the future. We just thought we had another decade or so. We didn't realize it sort of had to happen last year and this year. So there's a lot of changes that need to be made to support the out of hospital system, evolving very quickly and adapting, the tools that are right there now with augmenting those to support the kind of care models that are required to do all the incredible things that SLHD and other healthcare organisations have been doing. Particularly at the front end of that of all of that that patient load and managing complexity. So it's quite a challenge, because you're also trying to influence, people are learning as all this is evolving, and then you're trying to support them, but then they're so busy, and as you're saying, as Rich was saying, staff are burdened already with what they have to deal with in terms of with COVID, but then staff going out and being furloughed because of getting sick or contact precautions, etc. So it's been a really complex environment, and it's really been a challenge to be able to keep an eye on where things are needing to go, while at the same time you still got to go through a quality process of developing software and valid testing and all of the other processes that go on, and particularly in the healthcare area. So it's unlike, say, the internet, where you can just go let's move fast and break things, but in healthcare we have to move fast and not break things, which is way harder. And that's been a real challenge, I think, over the last couple of years, to in how to support our customers and partners to do what they need to do to deliver healthcare.
I want to pick up on that in particular, because from what I've witnessed anyway, in particular Sydney LHD and some of the initiatives that you've led out of there, Richard, a lot of them it's difficult to be one of the first movers, particularly in a public health setting, let alone just health in general. Take me through some of the thinking in terms of implementing some of these solutions and delivering healthcare with technology, kind of like flying the plane and building it at the same time. Like, how do you go about, doing some of that in such an important setting?
Look, with enthusiastic people like Malcolm helping us, with very understanding and accommodating clinicians, and also learning from others. So we've trailblazed in a few areas, but we've also picked up things that have been pioneered by others. The best thing you can do when you're trying to solve problems quickly is beg, borrow, and steal from people who've been there before. And so a lot of the models that we've implemented are based on tried and tested approaches, either to use video conferencing in healthcare consultations, to use remote monitoring, to develop various interventions that can help patients in either quarantine or in their own home. We've been leveraging evidence from around the world to build that. I guess the challenge for us has been that we had so much scaling to do so quickly. The quarantine hotel really tested our mettle, because we had thousands of people coming through every day, and these were return travelers who were not necessarily your backpackers or your healthy people that had gone on holiday. These were return travelers who had unmanaged diabetes, unmanaged cancer. We had pregnant women who hadn't seen their doctor throughout the course of their pregnancy because they've been waiting to come back to Australia, and then they're in quarantine for 14 days. So you've got to create new models of care, and you've got to pull in a whole quaternary health service around what can sometimes be relatively simple technology, but you've got to scale it quickly. So that's been a lot of fun. The areas that I'm interested in to really explore in 2022 and beyond, where we've started to see not just a substitution of face-to-face care with video, but really a redefinition of care by using either the store and forward model of capturing information from patients or interacting with patients, or even using things that leverage machine learning and other artificial intelligence platforms to help that just completely radically transform that patient engagement. My favorite one by far is the clinical trial that we ran with our virtual wound care management. Those of you who would be across wound management know that it usually involves pretty unpleasant stays in hospital. It's often very unpleasant for the patient because they have to spend a long time just sitting around waiting for things to heal. They have a lot of interaction with nursing staff. They have a lot of interaction with pharmacy staff and other allied health professionals to get their wounds looked after. And it's very inconvenient for them. We used an app as part of a clinical trial where we were taking photographs, allowing the patient to take photographs, giving them control of their own care plan. We're able to discharge those patients a lot earlier, and also transition a lot of their what were traditionally face-to-face visits to at home. And we compared that to a traditional model of care, and the results are just blown us away. We saw shorter length of stay, better patient outcomes. We saw lower pain. We saw better healing time. And all of that was using what we would consider relatively simple technology, but just elegantly put together.
I think it's a nice way to put it, is that, the technology doesn't need to be overly complex. It's more about how it all comes together. And Malcolm, more broadly then, seeing in other parts around the healthcare settings, is there anything that you've seen that's a good demonstration of what we can potentially continue to see moving into 2022 and beyond?
Yeah. I think the focus I think is particularly in current healthcare models, it's very much relying on clinicians looking at the patient and then looking at the data that's generated manually, and I think and then setting out some sort of plan, and the logistics of that are complex within the hospital, and they just get super complex outside of the hospital into community. And I think part of the challenge is just to get away from the idea that some clinician has to look at every bit of data. The idea is that as we collecting more granularity of data from wearables, from devices, or from images that may be taken from apps, etc., how do we automate some of that risk stratification, and then that's contextual as well, depending on the comorbidities. As Rich was saying, it's not, everyone's not the same. You have to also customize plans and what something means for an individual, like a new blood test result, blood pressure or whatever, or even a weight or something. Depends on what comorbidities they have and what is the meaning of that. But so we've got to build in that sort of level of smarts into the technology, so you can take monitor thousands and thousands of people out in the community where they're feeding in data, and they're sure that if anything is trending in an adverse way, that it will be brought to someone's attention, escalated. At the moment, we sort of have this view where an individual clinician has to keep looking at everything, and we have to kind of start looking at how do we transition into a more automated model with clinicians handling changes in healthcare trajectory rather than just basic data checking.
Yeah, totally. And I've noticed there's some good discussion that's happening in the chat there that's following a bit of a theme. If I take from George talking about the potential for residential aged care to be an extension of hospital care, but also Richard speaking about the need for more inclusion around GPs and rural. So there's often these discussions start to come up about not just bringing everything together in a hospital setting, but looking more broadly at the healthcare ecosystem. Is there work and thoughts that you guys have in relation to the importance of that? I might start with Richard and then go to Malcolm.
Yeah, there's some really nice comments in the chat. I wouldn't mind just picking up on what George Margellis is saying about residential aged care. I think not only with the Royal Commission, but also the impact that COVID has had on the sector. It shows us that we need to do more to really tear down these artificial boundaries that we have in the way that healthcare is delivered and managed across the system. It's very archaic, based around funding models, the difference between federal, state, private. Actually, at the end of the day, we have a vulnerable member of our community that has contributed to their community for most of their life, that now in a setting where they should expect, that should deserve the best possible and the highest standards of care and be as comfortable as possible. We've done our best through the course of the pandemic to really engage with both the publicly operated and privately operated residential aged care facilities and use virtual care, but also what we call our flying squads to go out and assist them. We've identified areas where we've helped strengthen with governance, with supplies, with training, or just being there to support those clinicians and staff members working in those facilities. But we really do need to do more. This, I think, needs to be a reckoning from 2022 and beyond, that we cannot turn a blind eye to the challenges our aged care sector has.
Totally.
Yeah, I think, absolutely, and I think one of the some of the challenges there, as pointed out, and it's similar in a way to the rural sort of side of things as well. And we do some work with our good friends at Murrumbidgee Local Healthcare District, and where you've got even within the hospital, you've got GP, VMOs operating smaller hospitals or clinics, and you might have complex patients there. And, you know, when do you bring them in, and who do you escalate to, and who's responsible? You know, because we've got this sort of very clear lanes of the healthcare system. And what we're saying is that even in an out-of-hospital program, and this came up with a project we're doing in South Australia around chronic disease management, even for a hospital run, if you like, telephone video service, the escalation points was still the GP. And then how do you bring them into the loop, and how do you make sure that the key data elements that if someone's escalated, can we check, have they turned up to their GP or not? Have they attended the appointment? What medication changes have been done to feed back into the chronic disease management program? So, and it's a very similar thing in terms of aged care as well. Like who do we escalate to? Because our platforms, I think about that a lot, because our platform's designed around decision support and notifications and escalation. So I'm always, our big area is, well, who are we escalating to? Who, from a clinical governance perspective, who's responsible? But that can change as to depending on the kind of changes that occur. So I think those are all. There are some governance challenges, there's funding challenges, but culturally as well. And then how do we break open those silos, from the hospital and GP different systems to allow key bits of information to occur at real time, so we know what's actually happening across that. From the consumer's point of view, they kind of think it should be a single system, and are often shocked when it isn't. And I think we have to kind of we've been able to sort of wave our hands around that to a certain point, but these new pressures are going to challenge those current lanes that we're sort of traveling in.
I'm seeing that in the chat too, in and amongst some of the OGs arguing about how many videos they watch on YouTube, but that's as an aside point there. But the other conversation that was happening in here was around that point of, Will's mentioned around getting that clinician buy-in, but also more broadly about a cultural.
So there's that expression, I think, I can't remember who said it originally, but you shouldn't let a good crisis go to waste. And at the moment, before COVID, we had burnout happening, and then COVID just added to that. And hopefully we'll get back to speak about clinician burnout, because we just haven't, there's been no room to even think about it, because COVID just added all this extra pressure. And what we talk about in terms of decision support is separating out memory tasks from judgment tasks. Right. So what we're, if we don't reduce cognitive burden and automate certain things first, there's no win in it. Because at the moment, a lot of clinicians, particularly with technology, when they hear about technology, it's just more time they have to spend, and the wins aren't always there. So I think interestingly, when we talk about that to clinicians and talk about it, all about automating stuff that should be automated. So actually, when we talk about a lot of decision support, some of the, I think clinicians are having to make too many decisions that they really don't need to. Some of it is just remembering, oh, this person's kidney function's not going so well, I better go check it up. And then if I do this, I need to change it. Some of that's just standard stuff. And so, we're not talking about fancy AI diagnoses or anything like that even. We're just saying automating the stuff we already know, so people have the time to think about things. You can't have a conversation about new models of care and all these other things if someone just is struggling to get home on time every day. That just doesn't happen. I mean, these are people who are under a lot of pressure. So the first point of decision support is to give people back some time and reduce their cognitive burden. And if you go in with that approach, you don't get arguments from clinicians. In our experience.
Nice one. I saw Pat mention something here which might eloquently kind of bring things together in terms of what's driving some of these evolving models of care. Do you think the strain on the health and aged care workforce is going to be the biggest driver for us to try and continue to shift? Like COVID brought around the necessity to do things virtually in different ways, but ongoing, is this going to be the biggest driver? Richard,
I think partially. I would say there's another important driver here, and that's the patient and their family. And the technology that we're starting to see implemented across the health system, where consumers and families get more control of their own information and take more control of their own journey through the health system, I think that's going to start to move the needle in really different ways. And we as a health system need to get better at sharing some of our inner workings and inner secrets. You know, if you want to navigate, if you've got a chronic condition or you've got something wrong with you and you want to navigate to get access to specialist advice in the health system currently, I got a feeling like you need to say good luck. You know, you have to go to the GP who may or may not know who you need to see. You need to go to an emergency department who may or may not be able to help you. You have to bounce around the system before you're able to work out what's the right journey for you to go on. And then even then it might change several times. We've got some great opportunities to use virtual care to transform that and involve consumers more and giving them more choice. And we also have to get better at accepting that consumers can make decisions. They can do more self-management. They can do more self-monitoring. And we need to get more comfortable about accepting those outside of the hospital walls.
I want to come back to a point that you made as well, Richard, just to continue on that a little bit, but to pull back to, you mentioned that more acceptance of some of these tools that allow some asynchronous communication, and you've touched on some examples there. And I know within the vendor community, good representation here at this event, as well as clinicians too, often that conversation kind of ends with, well, if no one's going to pay for it, then it's not going to happen. But we've seen also that there's kind of things we can be doing in the interim to be able to demonstrate the effectiveness of these types of tools. So it sounds like there's room for us to start utilizing these things now and demonstrate the effectiveness of some asynchronous communication tools that clinicians can pick up in between things and stuff like that.
Absolutely, there is. And I think the business case, it stacks up pretty nicely for a lot of these tools, right? It's a lot more expensive to have you in an acute facility than it is to have you in home getting virtual care advice. And often for the patient, that's a better clinical outcome for them as well. So there's an awful lot to be said for the very foundations of those business cases. I think that what I really need to see a bit more of is the vendor community taking some bets on hardware and software that is going to be more that redefinition space. We typically move towards the things that are safer bets in digital health, because we want to try and get in and land and expand. But actually now is the opportunity where health departments like mine are looking for new models. We're looking to transform the way that we provide care. We're looking for that new device, that new software that's going to help us make something different for our patients, rather than just something that's just video only enablement, if that makes sense.
Yeah, no, that's great.
Yeah, and I think that's part of an education thing as well, both in terms of, co-design, because we're not just designing purely for a consumer, it's in a system which is dealing with clinicians as well, and the kinds of interactions they need that we need to support. And I think also even just defining, we keep talking about, well, what data do we show patients, for example, and the idea that you have the same display of the data for the doctor or for the patient. And I think that's also really interesting to see, how do we adjust not just to language, but to levels of healthcare literacy and engagement models. So there's a whole lot of areas in this, it's a very big area. And I think we're only just really starting out, to move down, to take those things into account, to build out these kinds of really, engaging.
Isn't it so exciting though that we can now start to address some of those challenges? There's a whole landscape to go at, and the technology it's cheaper, it's more accessible. I'm sure there are people on this call already knocking out apps and all sorts of ideas that in the next 5 to 10 years we're going to really see transform the system. It's never been a better time to be in digital health.
I think, like Rich, like myself, are pathological optimists around this, obviously, which is why we're still in the game. But in the past, I agree with you. It's not a technology problem now. That's the good part. The bad part, it's more of a people problem, which is sometimes a bit harder, well, at least for me to deal with. But so I think that's right. The technology pieces are all in place. It's really about how do we work together to shape the tools.
Yeah. I feel like that's some really good closing comments, but just to start closing out this conversation further, there's some great conversation that's happening in the chat, echoing a lot of the sentiments around the importance of co-design and patient choice and bringing some of those elements into these things. But if there was one or two key points to take away from this conversation, I'll go to Malcolm and then Richard to close out things here.
Look, I think it's been, I think there's been so many challenges, and I think where we're landing up is that it is collaborative. It is going to require a lot of different inputs to evolve the technology in terms of really, again, just being more than the simple video or simple text message, and into a really, what we're trying to do is create smart assistants for clinicians and smart concierge tools for patients, so people can travel the journey through the healthcare system in a way that meets what they need. And I think those working with people like Rich and his team is fantastic, because I think there's a lot to learn over the next couple of years.
Indeed. And Rich, final thoughts?
I think 2022 is really going to be the year that we see some amazing things happen in virtual care in Australia and beyond. And I would just encourage people to be bold and brave, and to look for new models that redefine how people access the health system. And if you have challenges or you get resistance, that probably means that you're in an area where you need to push a bit harder. So I encourage you to do so.
Yeah. Well, it looks like the feedback from the session generally is that you guys need to push harder as well. You're looking great, apparently. So continue the great work, and let's keep the conversation going in the chat as we move on to the next session. Thanks, guys, so much for your time.
Thank you.